Well, welcome everyone to the official start of class today. Um, we are going to move right in and just welcome you to, let's say, is this week 6, I think, is that right? And
I think it's 7.
week 7, okay, we're in week 7, where we have Dr. Kim Price coming to talk to us about equity. We are just enjoying the class so much, and hope that you are as well. And let's see, before we jump in, I'll just remind you that we'll start with just kind of a brief opening where Dr. Price will share a few words. And then we also have our community guest who will share some words, whom we will introduce in just a second. And then of course, we invite all of you to chime in using the Q&A function. And we will get as many of your questions in as we can. And of course, to respect your time, we will end at 7. So we may not get to all of the questions, but we will try to get to as many as possible. Know that the session will be available as usual on our class YouTube channel tomorrow. And you can continue the conversation there. So Dr. Newton, are you there? Because we do not see you, and I don't see anyone. Where is everyone? Oh, there you are.
I was like, I see me.
I'm like, I'm the only one here. So I think now we'll go ahead with introductions.
Yes. And it's my pleasure and honor this evening to introduce to you Dr. Kimberly Price. She is an associate professor of public health, and I just learned just before we started talking that our LR program in public health, our Masters of Public Health, is nationally ranked a top 50 program. So bringing you a professor from this program, and she earned her PhD in health promotion and education at the University of Cincinnati, and she coordinates the undergraduate program in community health. She's been on the faculty since 2014 and teaches in the area of health promotion, planning and evaluation, epidemiology, and community engagement. So lots of things that are really relevant for our conversation here tonight. Before coming to LR, she worked more than 15 years in health education as a health education specialist in clinical and community settings, and she has devoted her career to promoting wellness and understanding social determinants of health, which is a term that we all now know the definition of thanks to Dr. Price's lecture. She's coordinated programs at Cincinnati Children's Hospital Medical Center, the New Jersey War-Related Injury and Illness Center, as well as other projects with not-for-profit agencies in urban communities. Her scholarly interests include reducing health inequities, addressing health literacy, and program evaluation and assessment. So welcome, and thank you for joining us, Dr. Price.
Thank you. Thank you so much for having me. It is my pleasure to be here. And are we introducing our other special guest?
Yes, now? Yes. I was just going to do that.
Yes, very special guest, I would say.
Yes, absolutely. So first we have Ms. Honey Estrada, and she is the president of the North Carolina Community Health Worker Association. She was born in Fresno, California, and moved to North Carolina when she was 11 years old. The daughter of Hmong immigrants who sought refuge in the United States during times of war, Honey understands the struggles families face in navigating various societal systems and the existing barriers that inhibit them from achieving positive outcomes. A proud community health worker, Honey has worked in healthcare and public health for over 20 years. Her experience is rooted in community health and advocacy. Throughout her career, Honey continues to serve as a catalyst for change when she champions racial and health equity. She holds a master's in public health from Lenoir-Rhyne University, where she was one of Dr. Price's first MPH students when Dr. Price came here in 2014. And she currently lives in Newton, North Carolina with her husband and 2 teens. And she teaches Zumba at the local library. Welcome, Ms. Estrada.
Thank you for having me. Super pumped to be here.
Sure. And we have another wonderful guest with us, Ms. Jazra Standley. She received her, her bachelor's in health policy and management in 2017 from UNC Chapel Hill. She recently graduated with her MPH from Lenoir-Rhyne University this past December, also one of Dr. Price's former students. Jazra is currently a health education coordinator at the Gaston County Department of Health and Human Services, which is better known in the community as just the health department. She started in the role of administrative assistant in 2017, and last summer she transitioned into the role of health educator. She is the assistant program coordinator for Strengthening Families, Draw the Line, and the Teen Parenting Program. She also plans the Summer Farmers Market Youth Program, POP Club. In conjunction with her former role as a student, she created a cultural competency training program around microaggressions and its impact on the workforce and health of the community. Welcome, Ms. Standley.
Thank you. I'm excited to be here.
Sure. And so now, Dr. Price, I think we are ready for you to get us started.
All right, let me go ahead and share my screen with you all. And this might look familiar to you if you were able to get through all the materials this week for our module. And we've been talking about health inequities. Health inequities is something we approach in a holistic manner in public health, because we know that what we do in public health and what we do in healthcare does contribute to who gets to live and who doesn't get to live. This diagram here is from the CDC, just representing the differences between equality and equity, and how it's important for us to meet people where they are and to give them the resources that they need so that they can live their full, healthy lives. Not everyone needs the exact same thing, and having differences is perfectly fine. But as an instructor, as a teacher, I wanted to get things started with just a little quiz. Are you ready for that?
Oh my goodness.
All right. Let me see. Is it recording? All right. So for this first question, which of the following is considered to be a social determinant of health? Is it housing? Is it education? Is it food? Is it social support? Is it violence? Could it be more than one? I need to move my over. Hold on a second. Okay, here we go. Actually, it's all of the above. Ding, ding, ding. I'm sure some of you got that correct, right? But it also includes things like transportation and employment, and even health behaviors. So social determinants of health are the range of personal, social, economic, and environmental factors that influence our health status. So you may recall that we had discussed how social determinants of health account for as much as 80% of a person's health outcomes. And in the United States, we do tend to focus more on medical care or clinical care, that quality and access part. But according to the World Bank, 50% of healthcare costs globally is spent right here in the US, even though we are only 5% of the world population. So we do spend a lot of focus on medical care and clinical care, but we must understand all of the contributors to our health. We have to address these as drivers of our health. How can we build a culture of health where we live and where we work and where we learn and where we play? You can see from this diagram that policies and programs, the social and economic factors in the physical environment contribute a great percentage of our health outcomes, but also health behaviors, our diet and exercise plan. But we also know that those health behaviors are influenced by how we live and where we work and where we learn. So very good. I'm sure many of you remember that from our lecture. So here's a true/false question. Racism. Racism can be both institutional and interpersonal. Is that true or false? It is true. It is true. Recognizing that racism or racial discrimination is real and that it still exists is an important acknowledgement. It's important to call it like we see it. Racism, as we learned in this module, can be institutional or structural. It can be personally mediated or interpersonal, where there's prejudice and discrimination, but it can also be internalized, that self-devaluation and sense of hopelessness that occurs sometimes amongst those of us in stigmatized, we take on this stigmatism that is put on us. But we need to work on creating environments that are more civil, more respectful, more inclusive. And we also need to promote those policies and practices that can help us to both examine and dismantle racism in our practices, dismantle the discrimination, whether it's intentional or unintentional. The racist position states that inequality or inequity or these racial disparities exist because there's some inferior race or racial group. The anti-racist position states that this inequality is a result of policies that are racist. So the problem isn't necessarily with bad people, but it's with bad policies that we allow to continue. So if we want to eliminate this inequality, we need to identify the policies that are problematic and try to really put forth effort to create equity and justice for everyone. I think we have another one, true or false. Race as a category on forms and surveys, and I'm sure you've seen them, is a way to measure social class, culture, and genetics. This might be a little bit of a tricky one because it could actually be thought of as both true and false. Using race as a variable is generally thought to measure like some combination of socioeconomic status or culture or genes, yet race is only a proxy or a rough proxy of any of those. So we customarily document the race-associated differences in health. We do that, yes, but we're just beginning to ask the question why. We're just beginning to really try to explain why do we see this. And so we're moving in the direction of not using it as a proxy for genetics or social class or culture, but as a measurement of racism. So, because we know that in regards to social class, for instance, Black people in the United States are overrepresented in poverty, but the majority of people in poverty are white people. And then we also know that not all Black people are poor. Regarding culture, it's difficult to say that there's a single Black culture, right? Because there's no single white culture or no single Hispanic culture or no single Asian culture. People who are considered Black in the United States can be as different as the Nigerian student or the Haitian American business owner or the Southern farmer or the teacher who teaches in an urban city in the Northeast. So with regard to culture, there's no one Black culture. And then with regard to genes, Black people or even white people in this country really represented like an admixture from places all over the world. And so in the United States, we do like to label people by race and we use it in forms and surveys and everything, but we have to remember that race as a proxy for social class, culture, and genetics is incomplete and it's inaccurate. It's more of a measure of our exposure to racism. And that's one thing that scientists and epidemiologists are understanding more and more, how racism can be the greater influence on health outcomes. All right, so now what are some examples of health inequities. If you recall from the readings or from the lecture, there were a few that were highlighted, one of which is maternal and infant mortality. In the United States, about 700 women die each year as a result of complications during pregnancy or delivery. And the CDC says that the, let me get it right, the pregnancy-related mortality ratios vary by race, with white women experiencing 13 deaths per 100,000 births. And we'd like to talk in rates in public health. So 13 deaths compared to 42.8 deaths per 100,000 births for Black women. That was in 2011 to 2015. And then many studies since then has suggested that it's really the implicit bias, whether conscious or unconscious, that is most likely the contributor to the racial disparity. There's also environmental protections. You may have read that article about the hog farms in North Carolina. They called them hog concentrated animal feeding operations. And they were disproportionately located in low-income communities and in communities of color. So the hog waste is often sprayed as fertilizer, and it becomes a pollutant that can contribute to respiratory conditions, mental health issues, quality of life issues, infectious disease risk. And we are seeing that as an environmental justice issue. And then, of course, another example of health inequities is what we see with COVID-19. We know that 1 in 735 Black Americans and 1 in 1,000 Latino Americans have died from COVID-19 in comparison to about 1 in 1,000 white Americans. And so this just shows how Black and Brown communities are disproportionately affected by COVID-19. Yet when you look at COVID vaccines, there are many more, I guess they call it vaccine distrust among Black adults and Hispanic adults than among white adults. And we use the term vaccine distrust so that we're not placing blame on the person, but on, again, it's on the system. Why is there a system of distrust between communities of color and the healthcare system? So that is really what I wanted to reflect on for this evening. And I'll just close with a brief story about my history. So I've lived many years, and unfortunately, none of my grandparents lived to see me graduate from high school, much less college or graduate school. And one of my grandparents I never even got to meet because he died when my mother was still in high school. And when she was in high school, the two of them were taking a trip in a car and got into a car crash, a car accident. And they were rushed to the hospital. But at that time, it was like the 1950s, and this was in Florida, in the South, and they weren't necessarily welcome to the first hospital that they were encountered. And so unfortunately, my grandfather did not live as a result of that car crash. And I don't know if it was just because at that time, if there wasn't a colored hospital that was close enough to be able to treat him, or if it was other things. But I still feel that that kind of structure that was a law and policy and accepted here in the United States, despite the fact that this was a family that had been in the United States, contribute to the United States, but did not have equal access to quality healthcare. It's tragic to have lost him, when he was still a fairly young man, leaving my grandmother as a young widow with raising children. So all of these types of things, these structural issues contribute to, and you could hear stories in healthcare or in education or employment that are very similar. But all these stories contribute to how we do have structural issues and systemic racism. But today, by calling it out, acknowledging it is one of the first steps that we need to take in order to dismantle it.
That was wonderful. Thank you for sharing wisdom. We already have a question queued up in the Q&A, but I'm going to be selfish and I'm going to ask one because I really appreciate what you're saying, that race, even within racial categories, is very heterogeneous. So like if you're Black, it doesn't just mean Black, it means Black with a certain background, a certain history and ancestry, and that there's a lot of variability in there, but yet we still use racial categories in medical settings. And so my first question for you is, well, you pointed out that it is predictive, that race can be a predictive category, but it's a social construct, not a biological one. So do you think, and this for you, Dr. Price or Ms. Standley or Ms. Estrada, do you think that there's ever an appropriate way, or is there ever a time when it makes sense to use race when making medical decisions? And then what about at the level of groups, so public health interventions? And then if it's not both, what's the difference?
Well, again, in public health, we try to approach communities and populations and develop strategies for that. And we customarily recognize looking at factors like person, certain characteristics of the person, the place, and the timing. We're trying to look at how outcomes and exposures are aligned. So there may be some room to, of course, recognize that this community or that community is at a greater risk for something, but it's still important to understand that you should not fall back to the way you treat people and to have the bias of stereotypes with that community. Many times with my work experience, when we would do community work, we would have all the data that's broken down by race or gender or age and zip code and everything to go into those communities. But what was more important was to go into those communities with an open heart and an open mind and ask them, what do they think are their key needs that need to be addressed? When you're working with people, it's more than just data. And sometimes if the data has information that could influence a bias that you may not even realize you have, it could influence how you care. So it's important to connect with the community, because as we become more familiar with people of different backgrounds, the more we can find those commonalities. We all want the same thing. We want the best for our children. We want to live our best lives. And how a person views it, it's important as a health professional to understand what the community wants, what their perceptions of their needs are. So I think we will continue to gather that information because we want to get to the place where we don't see racial disparities, right? So we are still collecting that, but when we do our approaches in community health, it's important to connect with the community and understand what their specific needs are from their perspective.
I think there's a good follow-up question in the Q&A. Because as you noted, Dr. Price, we all pretty much think that we want the same things. We just want to live our best lives. We want our children to be safe and successful. And so that's just, something that we all want. But we have a question here in the chat from Andy Massey, who says, public health is for the common good, but how do you respond to the individual who uses their freedom to make choices that negatively impact the public good?
It's a very good question. Especially in light of having to deal with an infectious disease pandemic, which we really haven't seen for over 100 years now. Early 1900s infectious disease, the leading causes of death in the country. But due to medical advances and the development of vaccines, for instance, we saw a lot of that decrease, and the life expectancy for everyone has been able to increase. And you know, we still have concerns about some of our chronic illnesses, but people were still able to live longer than with infectious disease. But then with COVID-19 here, we realized that yes, we have history to tell us about the importance of you know, having barriers to prevent the spread of viruses through masking, or we have vaccines now to help prevent this spread of the more severe cases of COVID-19. But it's still, there is still, of course, individual choices and freedoms that people want to exercise, because this is America. This is what we do. So it's a fine balance. When we know what is best for the common good, for our communities, for our children, for our country, but yet there are people who want to dissent from it. So in addition to imploring at the personal level, the individual level, when we establish policies and programs, we have to think about the general good. So that's where businesses and schools and government come together to start enforcing these public health mandates, whether it's for clean air and water, or vaccines, or, you know, healthy foods in our communities. All of those are public health measures that are aimed to help everyone. You might not get everyone to abide by it, but if you can instill policies to enforce those healthy behaviors, it's better for most people.
Mm-hmm. I think that's a great response. And it leads to another question that I had kind of been pondering after reviewing some of your materials, particularly in the Braveman and et al. Article. Quote, it states that systemic and structural racism are forms of racism that are pervasively and deeply embedded in and throughout systems, laws, written or unwritten policies, entrenched practices, and established beliefs and attitudes that produce, condone, and perpetuate widespread unfair treatment of people of color. That was a long quote. But zeroing in on that last part, that these systems and attitudes and practices and beliefs that perpetuate this widespread unfair treatment are just those beliefs and attitudes of people. And when I think about like the civil rights movement, it was often said, you know, it's a battle for hearts and minds as much as it is for politics, since it's the people who are making the policies. And so as we talk about freedom of choice and, you know, public health is the common good, what are your thoughts on what matters most for health equity? Are we looking for, you know, hearts and minds, or should the focus be primarily on policies and laws? Where's our battle here? And that's
again,
and any of our guests too who want to jump in, yeah.
Yes, again, I feel like it has to be a combination. We don't live in our public health sphere just using one approach. We use approaches in what we call the socio-ecological model. At the individual level, at the community level, organizational level, we look at infrastructure and policies and laws. And we have to do that because policies and laws help us to be able to make healthier choices in our individual choices and our community choices. So I personally believe that being able to establish programs and policies, having many people at the table as stakeholders to contribute to the ideas, because remember, for a lot of the history of America, everyone wasn't represented at the table. There are people who, even if they had good intentions of developing policies and laws for everyone, they could have some unintentional consequences once they looked at the health outcomes and realized there was continued disparities in health. So it's important to have diversity and inclusion at the table so that you can, when you are developing these policies, you can have different perspectives and see it in different ways. So I do think that that is vitally important, because those policies and laws will allow us to be able to make healthier choices and have more opportunities. But I'm sure our other guest speakers who are working on the ground with communities now can also contribute to this question.
So I'll jump in. Hello, everybody. Right now, in my current role where I am, I've been more on the hearts and minds aspect of it, because we have those policies in place that say, we're not discriminating this and we're doing this, and all that is great. But if the culture of the organization is not in that heart and mind place of we are going to and we expect nothing less, but to treat everybody the way that they deserve to be treated, then those policies and laws just, they just exist on a piece of paper in, the county intranet. And so the training that was mentioned earlier in my bio on microaggressions is something. Microaggressions is a relatively new term. A lot of people don't even know what they are, but they have been said to people forever. They've always existed. Just the term of what they are is not. And for those who don't know, microaggressions are kind of those verbal, behavioral kind of indignities that are a lot of times said verbally to people of color, but also just to those in minority communities, whether that's religion, sexuality, race, economic, it doesn't matter. And so that is kind of what my training has focused on, is kind of all that is affected by our bias. Now, we all have bias. It's natural. You can't not have bias. It's based on the behavior and your background and the daily experiences that you live. And so we a lot of times say without, thinking. We don't have to think about what's our next thought, what's our next move. And, that's fine. And that's great. That's how we go about our life and base our decisions. But especially in healthcare, that is also affecting the decisions we make for our clients without giving thought to what they actually need, what they want for themselves, what can actually help them. And that's kind of where those microaggressions come in, is if we can recognize that what we are saying is a microaggression, what it is, then we can start thinking before we say. We often think that we know what's best for our clients because we are the experts. But the simple thing is you just have to ask. You ask your clients, hey, you don't have to be as knowledgeable in everything. We don't know everything about every culture, religion, things like that. And so it's come into place where if you ask, if you can sit down and kind of humble yourself and just have that conversation with your client, yeah, it might take a little bit more time. But at the end of the day, that's what's important. We talked about mistrust of the healthcare system. If you are doing those microaggressions thinking you know best, and that's not really helping your client, why are they going to come back to you? And in certain communities, mistrust spreads. There are people who probably have never been to the health department who don't trust the health department. Because if their grandma went, their dad, their sister, they come back and say, hey, this is what this person said to me. They ignored me. They didn't care about what I had to say. That's a whole family. And if they're coming to the health department, it's probably the only place that they can seek care, or that they know to seek care. So now it's generational too. So now, that grandma is mistrusted, so now that daughter won't come. Well, then they tell that same story. So it's a generational thing. So if we can impact the people who are working in our healthcare system, that mindset of we have to change, and we're all to blame. No one is perfect. No one says the right thing. We all, say microaggressions. But we have to kind of work together on changing that mindset so that it's an organizational thing. And if it kind of starts at the top, it doesn't start at the bottom. Because if our leadership says this is not okay, and there's a consequence for those people who aren't, with that same mindset, then that shifts. Okay, wait, I can't say that, or there's a consequence.
Right. And it is true that it should be a systems-wide thing. Many times we think of cultural competency training or diversity training as being like an event instead of being infused within all the policies throughout the system. It's a better approach to look at things system-wide. And yes, even recognizing that you have a bias is better than saying, oh, I have no bias, and then still showing some implicit bias to your patients. Like Jazra said, it could have effects on many generations.
We have a question in the chat that we need to ask. It relates to this. And then I have a question that also connects. First, I guess before we go more into just the cultural humility training and just how we kind of try to unearth some of these attitudes and beliefs and biases. The question is, where is it there? Taylor, do you have it from Liz Ramsar?
Yes, I mean, exactly what we're talking about. And I think that Ms. Estrada is also going to have something to say. So she asked, how do you feel that overall healthcare mistrust impacts these outcomes aside from just vaccines? She asked this back when Dr. Price was talking about the COVID-19 pandemic and mistrust of that vaccination. But this is very related to what Ms. Standley was just talking about. Do you have a take, Ms. Estrada?
Oh man, that's a loaded question. So what's up, Liz Ramsor? I see you out there. And yes, Jazra, to all, like everything you said, yes, all of that, right? I think when we talk about mistrust, we saw this so much during the pandemic with vaccine. And what we know, and I've said this 100 times, is COVID, all COVID did was shine a light on all of the disparities.
Absolutely.
And so it's not something that's new. It was already there. It was just that now everybody saw it. And so this lack of trust, when we talk about distrust in systems, it's not something that's new. And I'm going to speak specifically about the Latinx community because we saw this. We go out and yes, we want to reach these individuals. And what's happened is they are so afraid of systems, and I say systems collectively, that when we approach them, it's like, and especially our undocumented population, it's like, what, we're here to provide information. We want to make sure you have these resources. We want to make sure that you have all the correct information and guidance to make the best decision. We want you to have informed decision making, right? All the good stuff. We're going to come out, we're going to provide testing, all this, okay? And then it's like, whoa, what? So what information are you going to collect from me? Because if I give you all this stuff, am I going to be deported tomorrow? What about my family? These are very real concerns. And so, just as Jazra said, this is generational, that generational trauma that we talk about, it is handed down from one generation to the next, and it spreads in community like wildfire. And when we talk about resolution, this doesn't happen overnight. It's not going to be, we're not going to find solutions for this overnight. It is continual. Like, we have to keep chipping away at this. We have to keep talking about it. We have to keep calling it out. We have to hold our systems accountable. We have to do better. And so, yeah, absolutely. When we talk about mistrust of systems, it's not just with COVID, it's with everything that came before COVID. All COVID did was amplify everything.
That's great. Well, there's a question actually in the Q&A that connects to a question that I have as well. And this is from one of our professors in the OT program, and that's Dr. Leslie James. And she's referencing the Saluja and Bryant article that you gave us to read, Dr. Price. And she talks about how it speaks to the impact of implicit bias and how it contributes to racial disparities and morbidity and mortality. And she just wants you to speak more to how having a greater awareness of personal implicit bias can help racial disparities across healthcare sectors, and maybe some tools. And I'm going to tag on to that, and we can repeat portions of this question if we need to. So she's looking for tools across healthcare sectors to combat implicit bias. And I would like to say, in the training programs, the colleges and universities where students are, where physicians, healthcare providers are learning, what opportunities do they have to unlearn these, implicit biases and just to unlearn the stereotypes? Particularly, I was struck by the quotation in the Solution Bryant article, in which physicians are said to think that, Black people have less sensitive nerve endings, thicker skin, and stronger bones. And so therefore, they have greater pain tolerance, and therefore will treat them based on the belief that they can take the pain. And I was just like, oh my gosh, that's just awful. And so somewhere in these training programs, they should be unlearning that, or what's happening in the training programs is what I'm saying. And so, yeah.
Yes, no, and that's, one of many examples where it does take some unlearning of what was taught or previously believed, and then just perpetuated from, one healthcare provider to the next in the training. But now there are many opportunities in order to intervene and to kind of change that system. Many opportunities because we are making progress. We are talking more about social determinants of health. We are talking more about racial injustice, and we're recognizing how racism is the variable that's the driver for racial inequities, and not simply, what we call race. When I'm not completely familiar with all the tools that are out there, but I do know that more and more is being developed. I know in many hospitals, the way they measure progress at hospitals, and I guess other institutions as well, the way they measure progress is like they're checking off for representation, like, oh, the EEO numbers, they're saying, oh, that's progress. But it's more than just, putting someone in the position, because, there are some organizations that have been, I guess, incentivized to put someone of color in a position, but then the weight of everything is on that one person's shoulders. So there needs to be a pipeline to make sure that there's enough people in the pool to choose from. There needs to be, an understanding in the hiring process, or even in the interviewing process, to make people of color to want to come to that organization and to increase representation. And then even with sustaining them, like what is happening 6 months or a year afterwards, is that person leaving? So a lot of our focus is on employment and representation in the healthcare field. But also, you even think about healthcare reform. For many years, especially like in the 80s and 90s, doctors were incentivized for volume. The more people they saw, the better things were. But with healthcare reform, we realized that what they call value care is more important. So doctors are able to spend more time with their patient, and having that time with your patient helps to build more trust. If there isn't that much time with the patient, you're going to fall back on those biases that are, ingrained in your head, because you just always thought that those Black people are different, or those Hispanic people are this way, or those Asian people are this way. So you fall back on those biases if you're not spending time with the patient and their needs, and getting to know what's going on in their lives, understanding, are they able to get the medications that they need? They're not just non-compliant. Are they able to have access to a reliable and safe transportation, or safe places to have physical fitness in their neighborhood? And I think that kind of approach in healthcare reform has been another opening for helping to reduce those racial disparities. We're not there yet, because we still have a lot of people who want to kind of not acknowledge that racism exists or that racial disparities exist. But you know, once we speak that truth and once we look at the policies that we have and we train not just at one level, but at multiple levels about cultural humility and about implicit bias and about microaggressions, then I think we'll be able to start measuring what our real progress is.
And I want to jump in on kind of how we can have greater awareness of our own personal implicit bias and learning more and stuff. One of the things that I talk about in my training, for lack of better terms, is to check your coworkers. If they are thinking that, you know, oh, this Black person, she can't feel pain, I'm a jabber, I can't find her vein, I'm a jabber in the arm 10 times until I can find it. She's complaining, but it's fine. Tell them. You don't be a bystander. That's one of the things. Don't be a bystander and sit around and let it happen, or they'll never learn. They can read something in a book 10 million times, but how often do we read and just, you know, you're reading so much and half goes out, right? So tell them, hey, you know, let me put you to the side. I think that patient felt uncomfortable. Why did you think that was appropriate? And that could be a learning opportunity. Sometimes it sucks to be that person that you feel like it all falls down on you to educate someone. But at the end of the day, who's going to do it? Especially if there is no, you know, cultural competency training. A lot of times they're not required. It's if you want to. And who are the people who want to go? People who already believe that this is a thing. So if it's not mandated, then they're never going to learn this information. So that's one of the things. And to learn your own, one of my favorite websites, some people don't like it, but I do, is called Project Implicit through Harvard. They have a health version, and they have tests for you to determine your implicit bias on several categories, on obesity, on religion, on race, things like that, nutrition that affect healthcare. And it's just a simple, quick, you press 2 keys on what you associate with which category. And it's not a set in stone thing like, oh, you're definitely biased against this, but it gives you kind of a, okay, maybe I can work on this myself in this category. And there's always work to be done. There's so many research articles on implicit bias, especially lately in healthcare. So there's always something to read or reach out to, you know, if there's a health equity staff at your organization or things like that, to just see if you can sit down and have a conversation. And also ask your patients, ask the people who you serve, is there anything that I say or that I do that's making you feel uncomfortable, or that you feel like I'm not listening about something? Because we can tell somebody, I need you to lose this weight. I need you to run around your neighborhood. But what if their neighborhood's not safe? They can't afford a gym. They're not disobeying your request for them to lose weight, but the other systems that are in place are against them. They can't go run outside. It's not safe. Maybe there's no sidewalks. A lot of times in the South, when I moved here from California, there's hardly any sidewalks unless you live right in the main city. So that's an issue that, you know, they're not trying to disobey you as a doctor. They may really want to lose that weight. So maybe you sit down and work out, okay, these are some things you could do at home. Walk up and down the stairs, go do this YouTube video, print out papers of workouts that they can do in their living room with their family, things like that.
Those are a great idea. And I think it leads to what we kind of learned from the groundwater article, and also the video about the allegories of race. And because what we're talking about, what you said is, okay, if they don't have sidewalks, you know, now we're talking about environment, we're talking about the soil that they're in. And you know, in the TED talk with Kamara Jones, she talks about how the soil, if the soil isn't good, you can't thrive. And the groundwater isn't good. That's why the fish are coming up dead. Now, a lot of that soil and groundwater is based on historical policies, right? I mean, that Braveman article tells us that many of the negative outcomes are a result of things from history, policies that were placed, you know, that were originated in historical times, but we're still feeling the effects. And so I guess I just wonder, where can we look for hope there? I mean, we can talk about the cultural competency, you know, the cultural humility training, but if the soil is bad, what can we start doing about the soil?
Well, I think there are a number of things that can be done and are currently being done. One way to kind of like bridge the gap between the medical institutions and the people is the use of community health workers. And I think I'll turn this over to Honey to talk about some of her experiences, not just with community health workers, but also understanding the social determinants of health when we're looking at one neighborhood versus another neighborhood.
Oh man, she's talking about community health workers. That's my heart right there. Yeah.
Yes.
Yeah. And so, you know, for those of you who might not be aware of what a community health worker is, so community health workers are trusted members of their communities. And, you know, it's not new. It's not a new thing. Community health workers have been around for a long time, but there's a lot of energy surrounding community health workers right now. Specifically with the pandemic, there was a huge push to really deploy CHWs, community health workers, to CHWs in communities. And, you know, I think that when we look at strategies and things like that, and really looking at the soil, it is really looking, one of the, you know, if you listen closely, the community will tell you what they need. They have the answers. They have the answers. We just have to listen. We just have to listen to them. That's what community health workers can do. They are trusted members of they know those cultural values. They know the nuances. They know what works. They know what doesn't work. They look like the communities they serve. They speak the language. And so they're able to be an advocate, a coach, a liaison between that community member and the healthcare team. And, you know, historically, community health workers come from disparaged communities. So a lot of times these are individuals who are doing this work on a volunteer basis or for free. My mom was the first community health worker I've ever known. And so really leaning on these individuals, there's a lot of energy surrounding community health workers right now to address needs. I know specifically for Catawba County, I previously worked at the health department. So not too long ago, we received some funding to support community health workers. We were very intentional about onboarding these individuals. We didn't put out, we didn't broadly broadcast the need for these folks. We were very specific and intentional to identify folks from within the community who had connections, who looked like those communities, who spoke the language, to come back and help us do this work. And their jobs were to connect with community members and connect them to vaccine resources, to provide education and get them signed up for vaccine. And if we look at the data, you could see where the CHWs, where they hit the ground running, because the numbers were very white. Okay. Now, I will say there was also eligibility requirements and all of that we have to take into consideration, but it was very white. And you can look at the data and see it was when they hit the ground running, when they hit the ground and went out with their laptops and their hotspots and were able to reach those communities, specifically communities of color, and say, hey, what do you think about the vaccine? What if I go ahead and get you registered and we can get you scheduled for an appointment right now? We saw those numbers go up. And so you can't sit here and tell me that CHWs aren't effective at reaching communities of color. They're very effective. And on top of that, they're able to add so much value to the healthcare team. They're able to see things beyond the 4 clinic walls that primary care, those primary care providers, the nurse, the physician inside of that practice, they're never going to see that, because the CHW can go out to the patient's home, see what's going on. Jazra was talking about, if somebody can't, we have a community member who can't go outside and run or walk because it's an unsafe neighborhood. That community health worker can come back and say, hey, let's talk about this a little bit more. This is what I'm seeing. Let's talk about how we can, some other options and how we can really achieve positive health outcomes for this family, because they're experiencing barrier A, B, C. These are the challenges they're facing. How do we address this? Let's come together and create an action plan that is going to help this community member and their family be very successful in reaching those positive health outcomes. I can talk all day about CHWs, but I will pause there.
Yeah. And no, thank you, honey. I think that is excellent. And it allows us to celebrate those milestones in the community that maybe the doctor's office does not see. It might be the celebration of the person who turned 95 years old in the community that doesn't really get a lot of recognition when you're just reporting the statistics of, you know, the lower life expectancy. Or maybe it's celebrating the young African-American or Latino student who graduates at the top of their class and got multiple offers to colleges. And that is celebrated within the community that it might not necessarily be part of their medical records, but it is an important recognition to show value and that people are thriving in all communities. Even though we still see some of the disparities as well. So it is important to celebrate the good, what we call in public health, we love to use theories, but the appreciation inquiry model to make sure that we are understanding where the perspectives of our community and celebrating with them what is positive, what is good, what is going well.
I love that point, that, and it ties back, I think, to what you were saying about representation. Something about representation and everybody having a seat at the table allows us to appreciate the fullness of the people that we serve, right? Whoever that might be. And Dr. Carol and I, we were having a conversation this week, we were kind of joking about it a little bit, that in teaching a class like this, it's so easy to focus on the negative because the systems are so diseased. Since we're talking about health, the systems have so many problems that's really easy to only talk about race in a negative way, to only focus on racism instead of these positive aspects of full human beings that y'all are appreciating. So thank y'all for the work that you're doing. And maybe with that, I'm going to pivot again to something negative, maybe with our last few minutes. So speaking of representation, Dr. Price, in your lecture, you point out that addiction is treated differently in communities of color versus white people. And that you linking it back to what we were just talking about, you say that it might have to do with physicians' ability to identify with their patients, so to empathize with it. And I wondered, in speaking about addiction, do you see that differential racial dynamic playing out in the current opioid crisis with the attention that's paid to it and the framing of it? Is that a thing?
I remember a few years back, there was a physician who specialized in addictive disorders who came to speak to one of my classes. And he did speak a lot about how the opioid epidemic has been very different from the crack cocaine epidemic that we had, and how we treated the patients and the resources that were put behind it, just many, many differences. And even how, how it is just portrayed in the media as well, with crack cocaine or being really demonized and criminalized, whereas many times, not all times, but many times with opioid addiction, it was, because they got addicted to painkillers, it was not a street drug or something like that, as though that made it any better or worse. But when you boil things down to it, we all, need help at some point in our lives. We all have a struggle with something. So why should one person's struggle and the reaction to that struggle be so different than someone else's, simply because of the color of a person's skin or even just the perception of where that person is coming from? I know that there has been a lot of progress with sentencing for powder cocaine versus rock cocaine because of the disparities in race. There's still in some communities, there still seems to be a controversy with the use of Narcan and helping those who are addicted to be able to basically have their life saved if a first responder is able to reach them and give them what they need, just to have the ability to have an opportunity to go through rehab or to recover. But we unfortunately, we still see some of this bias in our healthcare system, as well as in other systems that, I don't know, sometimes it does seem hopeless, and I try to be an optimistic person. So I do believe that things are getting better, but again, it calls for settings like this where we can call things out as being discriminatory, being racist, whether it's intentional or unintentional. If it is something that needs to be approached, we have to first acknowledge it. And there are plenty of people who care enough to make these changes that we can do it, but we have to work together.
And I think three of them are here with us tonight. So thank you again for the work that you do. We've gone a little bit over. I asked a big question there at the end, so I'm sorry we didn't get to hear from Ms. Standley and Ms. Estrada about that question. But we are at the end of this week. Thank you so much for joining us this evening. This was an exciting week for me. We tied together a lot of threads. We talked about history, we talked about biology, we talked about the psychology of implicit bias, we talked about systems and Dr. Stokes this week. Things are kind of coming together to paint a holistic picture of our understanding of race and racism in America, and that's exciting. We're going to get to continue that exploration starting in 2 weeks. So we won't be meeting next week. We will come back in 2 weeks because it's our spring break and Dr. Carol and I are tired. So we're going to take a little bit of a break. And then after spring break, we'll be joined by Dr. Janelle Carter-Robinson, who's going to be talking with us about inequities in the mental health system and things like stigma and treatment and the impact of race and racism on mental health. So it's going to be a really exciting and important week whenever we come back. You can look for a recording of this lecture to be posted on Canvas and YouTube tomorrow. Thank you to our guests. Thank you as always, Dr. Carol. This was a great night.
Yes, thank you all. Thank you all.
Bye, everyone.
Bye.